This presentation is regarding the drug therapy for rheumatoid arthritis. Rheumatoid arthritis, or RA, is an autoimmune inflammatory disorder that affects about 1.3 million Americans, and though it develops at any age, usually the initial symptoms will start to appear around the third and fourth decades of life. With our younger patients, incidence of rheumatoid arthritis is more prevalent in females than it is in males at a rate of about 3 times. Our patients that are older, over 60 years old, the incidence with rheumatoid arthritis is actually equal between men and women. And it will follow a progressive course that eventually will cause further joint deformities and functional limitations. In many cases, drug therapy is warranted, and today we're going to talk about what type of therapy we can use. Remembering the pathophysiology of rheumatoid arthritis, we have a healthy joint that soon, for different reasons, can have inflammation of the synovial membrane. This inflammation is going to progressively turn into the onset of pannus formation and cartilage erosion within the joint space. And as this pannus forms and progresses, cartilage will further deteriorate. Rheumatoid arthritis is a disease process that is accompanied by complete destruction of the joint cavity itself, and together there's going to be a fusion of the articulating bone that is being affected. You will have signs and symptoms that are symmetric because it is a systemic disease process, unlike osteoarthritis, and there will be systemic joint stiffness and pain. Mostly this joint stiffness and pain is going to be more intense in the morning, and it slowly starts to dissipate as the day advances. The joint itself, upon physical examination, could appear swollen, tender, and warm. There are 3 major types of drugs that are used to treat rheumatoid arthritis. These are the nonsteroidal and anti-inflammatory drugs, or NSAIDs. We have glucocorticoids, and we have disease-modifying anti-rheumatic drugs. Now, the prototypes within each of these classifications: for NSAIDs, we have aspirin, which is a first-generation type NSAID, and a second-generation NSAID would be Celebrex, or also called celecoxib. This is a COX-2 inhibitor. The prototype for glucocorticoids is prednisone, and the prototype for disease-modifying anti-rheumatic drugs, or DMARDs, there's actually 3, and they fall under different categories. Methotrexate is a conventional DMARD, where etanercept is a biologic DMARD. We also have tofacitinib, which is a targeted DMARD. And DMARDs are drugs that reduce joint destruction and slow the disease progression, and they do this by interfering with the immune response and the inflammatory response. They have extensive effects on the immune system, and the conventional DMARDs specifically are small molecules that are synthesized using conventional chemical techniques, where the biologic DMARDs, these are larger molecules produced through recombinant DNA technology. These drugs work on cytokines. And lastly, the targeted DMARDs, they are going to be smaller molecules that are synthetically developed, and they are going to block the specific pathways inside the cell of the immune system. There are some considerations when deciding which drug to use. In terms of life stage considerations or lifespan considerations, with children and adolescents taking a TNF antagonist, they've actually developed lymphoma and other malignancies. With pregnant women that take biologic DMARDs, we know that the TNF antagonists are at a pregnancy risk category B. Other drugs you see are category C, like rituximab and abatacept. There are non-biologic DMARDs that also fall in this category B zone. We have sulfasalazine, which is a pregnancy risk category B, and both azathromycin and leflunomide and methotrexate can cause teratogenic effects and fetal death. Hydroxychloroquine may cause fetal ocular toxicity when given to a woman during their pregnancy, although there are some conditions where we can't get away from that, such as maternal lupus or malaria, in which at this time the drug will decrease fetal risk associated with the condition that it's treating. So there is a risk benefit that you need to weigh. For our breastfeeding women, we do not recommend or prescribe DMARDs for women that are breastfeeding. And for our elderly patients, they may be at a greater risk for infection, which is secondary to the immunosuppressive effects of the DMARDs in all classes. So NSAIDs, just in general, they are going to be prescribed for anti-inflammatory and analgesic actions. However, when you are prescribing for rheumatoid arthritis, the prescription strength really is going to be a lot higher than you would just to treat maybe a fever or a little bit of pain. And there are two main classes of NSAIDs. We have the first generation NSAIDs, which inhibit both COX-1 and COX-2, and we have the second generation NSAIDs, the COXIBs, and these only selectively inhibit the COX-2. Now, all prescription strength NSAIDs, they do carry a box warning regarding the risk for thrombotic events. So if you already have an underlying GI disorder like PUD or any other type of ulceration, then you are going to be at an increased risk of bleeding, and therefore you're not a candidate for taking NSAIDs. If you have an underlying bleeding disorder or are in a hypercoagulable state, you also should not be on NSAIDs as well. The risk for GI problems, though, is actually less when you take a COX-2 inhibitor like Celebrex. Now, the dosages are going to, again, be considerably higher, so make sure that when you are dosing the NSAIDs, you're looking at the indication to help you to determine how high these doses need to be. In terms of efficacy, all NSAIDs have essentially equal anti-rheumatic effects. However, some patients may respond to one NSAID better than another, and therefore, what you would try for one patient may not work for another patient. So I like to ask them what they've already tried and if they've been on other treatments that have been prescribed by their rheumatologist. The prescription strength NSAIDs are relatively less expensive than our DMARDs and even some of our glucocorticoids. So usually for me, this is going to be first line so that we can start from here and see if we need to add anything else onto their treatment plan. First generation NSAIDs are salicylates, which are aspirin. We also have magnesium salicylate. This is sometimes marketed under the trade name Doan. First generation NSAIDs like diclofenac, ibuprofen, indomethacin, and meloxicam are just some of a very extensive list that you can look up in your textbook. But these are very common ones that many of you might already be familiar with. And then celecoxib, which is the trade name Celebrex is under the second generation NSAID category, and this is only selectively inhibiting COX-2, whereas the first generation NSAIDs will inhibit both COX-1 and COX-2. Moving to glucocorticoids, remember that this is also a powerful anti-inflammatory drug that can relieve your symptoms of severe rheumatoid arthritis. I very rarely will prescribe this to someone that hasn't already been treated with an NSAID unless there was some contraindication or underlying disease process that would make them not a candidate for NSAID treatment. For generalized symptoms, you can give oral glucocorticoids, but if it is just one or two joints that are being affected, you can look into intra-articular injections directly to that joint space. In theory, glucocorticoids should only be used short-term because long-term therapy can cause serious toxicity, leading to osteoporosis, gastric ulceration, and even adrenal suppression. If glucocorticoids aren't working or they have decreased in their efficacy, this is when it's time to start thinking about maybe DMARDs to better control the symptoms. The next few slides are not going to tell you too much about these DMARDs, but rather give you a list of prototypes under each of the different types of DMARDs. And so for the non-biologic or traditional, sometimes called conventional DMARDs, we have Plaquenil, which is the trade name for hydroxychloroquine. We have Monoxin, which is monoxilin, and cyclosporin. Those are ones that probably most of you are more familiar with, but you see there's this secondary list that I put up here, and you can see further information in your textbook. For the major biologic DMARDs, or the tumor necrosis factor inhibitors, we have Enbrel, Humira, and Remicade, and these have been recently, or more recently, been heavily marketed on TV, on the radio, and at the doctor's office. And so you might be more familiar with these drugs. They work really well. But again, I don't always start with these biologic DMARDs if I haven't tried conventional DMARD like methotrexate. And you can see there's additional ones listed here, but also check out more in your textbook. And finally, under the last category, we have Rituxan, which is also used when other drugs have not been proven to be successful. And there is more detail in your textbook regarding these biologic drugs as well. You can see on the slide that there's many different types of conventional or traditional DMARDs that come in different preparations and prescription doses, as well as different ways to administer. You can have, in terms of methotrexate, which is a very popular conventional DMARD, it can be dosed orally, sub-Q, and IM. Sometimes you can give it weekly, and you're watching for this optimal response to be achieved, or you're looking for the maximal dose to be reached. There's also some optional oral dosing that can occur. It does start between 10 to 15 milligrams each week initially, and then you can increase it 5 milligrams a week every couple of weeks until you get to a maintenance level of 20 to 30 milligrams every week, and then you would just continue that. So you are stair-stepping up into a comfortable dose. You can see that many of these drugs are prescribed in incremental doses, and once you get to a dose that is relieving the pain, or the loading dose has been given, and you hopefully will find a good maintenance dose for your patients. Here are a list of the biologic DMARDs and their dosing schedules, and you can also see how they are prepared as well. Here you can see there's currently only 2 targeted DMARDs, and the first one, tofacitinib, this actually comes in extended release tablets as well, which makes it great for only dosing once a day. And the last one, baricitinib, can also be dosed once a day as well. In terms of the pharmacokinetics of the DMARDs, the conventional DMARDs here you can see with azulfonide, there is a 6-hour peak, and it is metabolized by intestinal flora, eliminated in the urine, and does have quite a long range in terms of half-life, or a broad range in terms of half-life. You see with hydroxychloroquine, we don't really understand where that peak is, and it does have a 40% protein binding. It's primarily hepatic metabolism and urine elimination with a 40-day half-life. So it does extend for long periods of time. And you're going to notice with the DMARDs just in general that they have longer half-lives than other drug classifications. Many of the biologic DMARDs, we don't understand their exact protein binding and their metabolism or elimination. However, understanding the half-life, you can further start to connect why the dosages are so wide. So let's look more closely to this prototype methotrexate, which again is a conventional DMARD. The mechanism of action of methotrexate is important. It's a folate antagonist, and it is the DMARD of choice. It has a very high efficacy, it's relatively safe, it doesn't cost much, and extensively it is used for rheumatoid arthritis. At least 80% of our patients will see improvement when on methotrexate. It does act faster, giving a very quick therapeutic effect. Developing in about 3 to 6 weeks, you will have sustained reduction of symptoms. It does lead to immunosuppression secondary to reducing the activity of the B and the T lymphocytes. I do want to spend a little bit more time going over what this means being a folate antagonist. Now, folate is necessary for DNA synthesis and cellular replication, and it's going to inhibit these processes, which will then allow the benefits of methotrexate to be achieved. It's going to first result, again, due to the immunosuppression that's secondary to reducing the activity of those B and T lymphocytes. Though methotrexate is a great drug for our patients with rheumatoid arthritis for the several reasons that we've just went over, the adverse effects are not negligible. We do have major toxicities that include hepatic fibrosis, bone marrow suppression, GI ulceration, and pneumonitis. However, we can reduce GI and hepatic toxicity by supplementing dosing with folic acid. So if we give at least 5 milligrams a week, which is recommended, we can reduce these risks for adverse effects. Now, supplemental folic acid enters the cell passively, and it doesn't compete with methotrexate, and this is why it works pretty well. But you do want to also think about testing the liver and kidney functions, which is going to be mandatory when you are dosing someone on or prescribing someone on methotrexate, as well as getting a complete CBC, including platelet counts. Methotrexate can cause fetal death and congenital abnormalities, and again, it is contraindicated during pregnancy. You don't want to prescribe this during pregnancy, so many times if you are working with the patient that could potentially be pregnant, you do want to obtain a pregnancy test before starting them on methotrexate. Recent data has actually shown that When you use methotrexate for rheumatoid arthritis, this may lead to a reduced life expectancy, and this is owing to increased deaths from cardiovascular disease, infection, and certain cancers like melanoma, lung cancer, and non-Hodgkin's lymphoma. Just going to reiterate one more time the black box warning for methotrexate. It is contraindicated for women who are pregnant or women that are nursing. If you have any type of blood disorder, if you have underlying immunodeficiency or liver disease, this is also a reason to not take methotrexate as part of your rheumatoid arthritis regimen. It will increase the risk for serious myelosuppression when you are prescribing it to patients that are on other drugs that can also decrease bone marrow function as well. Methotrexate does reduce the response to vaccines, and it decreases the efficacy of these vaccines. Live vaccines are contraindicated for any patient that's taking methotrexate. It's necessary to only give inactivated vaccines that are killed and not live to patients receiving methotrexate, and these patients should be revaccinated within 3 months after the therapy is discontinued. Ideally, the vaccines that you need should be administered prior to starting methotrexate. So if you know that a patient is going to start this treatment plan, make sure you go through their vaccination status to see if there's anything that they need before starting. And the vaccines that you're thinking about or should be thinking about are the ones for communicable diseases like pneumonia, influenza, hepatitis B, HPV, and herpes zoster. We're now going to move on to Plaquenil, which is hydroxychloroquine, and this is primarily used as an anti-malarial drug, but it's a preferred DMARD for rheumatoid arthritis treatment. It's usually going to be combined with methotrexate as well. However, by itself, hydroxychloroquine doesn't slow the disease progression, but you can use it to improve long-time symptoms. In terms of the mechanism of action, it is still unknown why or how hydroxychloroquine works with rheumatoid arthritis. There is a delayed onset where you're not going to get the full therapeutic effects until about 3 to 6 months, and using concurrent therapy with anti-inflammatory agents like NSAIDs or glucocorticoids can be indicated during this latency period while you're waiting for hydroxychloroquine to work. There are some adverse effects with hydroxychloroquine, though many people do tolerate it pretty well. If there's any type of GI distress, it can be relieved with food or milk. And so many times you're asked to prescribe this medication and teach your patient to take it with food. There are some serious toxicities that are also not negligible with hydroxychloroquine, which is retinal damage. Though it's rare, it can be related to the amount of medication you are prescribing. So the higher the dose, the higher the chance of retinal damage. There are also some cardiac problems associated with high dose as well. Cardiomyopathy with varying degrees of AV heart block and bundle branch block can occur with high doses of hydroxychloroquine. We also have prolonged QT interval. There's a risk for ventricular dysrhythmias that are also increased while on hydroxychloroquine. So obviously, if you're a patient with these underlying risk factors, or you already have these underlying cardiovascular dysrhythmias or arrhythmias, then you shouldn't be a candidate for hydroxychloroquine. It can also lead to hypoglycemia, proximal myopathy, neuropathy, and worsening of previous psoriasis. You can see the different types of tumor necrosis factor inhibitors here, starting with Enbrel and moving through to Cimzia, and they are all indicated for rheumatoid arthritis. However, I do like this chart because you can see all the other types of diseases that we do use DMARDs for, including ankylosing spondylitis. We can use it in juvenile idiopathic arthritis, but there's only two, Enbrel and Humira, that are indicated for this reason. For psoriatic arthritis, we can use all 5 of these TNF inhibitors, and plaque psoriasis, you can use Enbrel, Remicade, and Humira. We also use this for inflammatory bowel disease. Specifically, Remicade and Humira can be used to treat Crohn's disease and ulcerative colitis. However, the newer type DMARDs here at the end, the Cimzia can treat Crohn's disease, and Simponi can treat ulcerative colitis. There is a black box warning worth mentioning for tumor necrosis factor inhibitors. Patients that are taking tumor necrosis factor inhibitors, they are at an increased risk for developing serious systemic infections and sepsis. And lastly, there's a long list of key prescribing considerations that can be found in your textbook. Reviewing that the therapeutic goal of prescribing for rheumatoid arthritis is to relieve the symptoms, to maintain joint function, range of motion, minimize the systemic involvement, and delay the disease progression. At baseline, you want to make sure you're getting a CBC with WBC differential. You're assessing for the signs and symptoms of infection, especially if there is TB and hepatitis. You're also looking for any skin malignancies, specifically by doing a skin examination. You're ruling out pregnancy for anyone that is of childbearing age, whether they believe that they are pregnant or not. Remember, there is a black box warning for methotrexate specifically. You're screening for TB, getting a complete history and physical exam, and you're trying to establish a pre-therapy status. The emphasis should be placed on knowing the risk of immunocompromise or immunocompetence and liver and renal status, all before starting your patient on DMARDs. Now, there's additional baseline data depending on what type of DMARD you are prescribing. So for conventional DMARDs, you're also going to look for liver transaminases by getting an ALT and an AST and serum creatinine. For methotrexate, also consider a chest x-ray because you're looking for any pulmonary disease or GI disease. With hydroxychloroquine, you might want to get an eye exam, check the heart because of the adverse effects like retinal damage and cardiac arrhythmias. You will get an EKG. With all biologic DMARDs, you are screening for HBV and again TB like we discussed earlier. For our TNF inhibitors, think about getting a baseline cardiac status and screening for demyelinating disorders, severe heart failure, active infections. With certain drugs, you may look to see if there is B lymphocyte depleting agents, like when prescribing rituximab. And with the interleukin 1 receptor antagonist, you might get a serum creatinine to screen renal failure. Now, the list goes on with the other types of DMARDs, and you can see these in more detail in your textbook. In terms of monitoring all the DMARDs, you will get a CBC with WBC differential. Everything you did before prescribing, you're also going to monitor the same types of labs. Specifically with our DMARDs, except for hydroxychloroquine, you will get a CBC with WBC differential. You're checking liver enzymes, serum creatinine about every 2 to 4 weeks for the first 3 months, and then you can progress on to every 8 to 12 weeks for months 3 to 6, and then every 12 weeks for the duration of the therapy. So there is going to be frequent and long-term monitoring that is required for patients on DMARDs. There's no follow-up on these lab studies when you are prescribing hydroxychloroquine. There's nothing that's currently recommended, but it is prudent to get some baseline information just in case there is some rare abnormality that exists later on. I would go back and look at the uh, the risk panel and the side effects, the adverse side effects specifically for all these drugs to determine what you would monitor for safety. For more information about the key prescribing considerations, I advise you to look into your textbook because the list is too extensive to put here in this presentation.